Hello, and welcome to the Alabama Public Health Training Network. Tuberculosis, or TB, is a highly contagious bacterial infection that can quickly spread if not caught, isolated, and treated early. Today, we will discuss the basic principles of tuberculosis, including how it is contracted, how the effect TB has on different organs and systems. Thank you for joining us today for Part 1 of our two-part program, Tuberculosis 101 for Disease Control Staff. If you have questions about anything discussed today, please call or email our faculty presenter during our live broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheets, and evaluations are all available online. You will need to register for the program in order to access these materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program and then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credits will only be awarded for 1 year and will expire December 31st, 2015. I'm Pam Barrett, Director of the Division of Tuberculosis, and with me today is Dr. Karen Landers, Assistant State Health Officer and Pediatric Tuberculosis and Immunization Consultant. Hi, Dr. Landers.
Thank you very much for inviting me to speak today. And I think that what we want to talk about today is an extremely important issue to all of us who are involved in medical care, be it primary care or in tuberculosis control. And while our focus today is going to be Tuberculosis 101 for the disease control staff, much of what we're going to say today will also be applicable to other disciplines such as social services and other programs that work with us in taking care of patients with tuberculosis. As Pam mentioned, the basic information we're going to provide today is what is tuberculosis? Transmission and pathogenesis is another subject that we will cover. We want to talk about how humans contract tuberculosis, and this is really important because many people still have a lot of fear about this disease and the effect of tuberculosis on different organ systems, as well as talking about the difference between TB infection and TB disease. And these are very important concepts as we take care of patients. So what makes TB unique in medicine? I've had a lifelong interest in my career in tuberculosis. I like to say that I became interested in this when I was a junior medical student at UAB and had the privilege of working with Dr. William Bailey, who, again, at that time was a young doctor, fresh out of training and working in pulmonary, and now Dr. Bailey is chairman of our TB Advisory Committee. And when I first learned about tuberculosis is that tuberculosis is a social disease with medical aspects. And this was actually said by Sir William Osler at the turn of the 20th century, Sir William Osler being a very, very famous internal medicine physician at Hopkins. When we look at the transmission and pathogenesis of tuberculosis, what again makes this unique? Well, first of all, everyone exposed to tuberculosis is not going to develop tuberculosis. However, in a situation where a person is exposed to tuberculosis based upon the factors of infectivity, and we'll talk about that in just a minute, the overall risk of infection in a large population exposed to a case of tuberculosis is about 30%. So, if you're exposed to a fairly infectious case, then the risk is about 30% that you will become infected, again, depending on multiple factors that we will talk about later in the program. There's a 70% chance that you will not become infected. And I think these are important concepts because I receive phone calls and communication periodically from our disease control staff here when a person has been diagnosed with tuberculosis and someone knows a person who knew the person who had tuberculosis, and they're very concerned that they're going to contract tuberculosis. If they were not around the patient, they're not going to get TB from that patient. So I think, again, looking at the risk overall of infection is very important. Okay, let's talk about that 30% of people, let's say, that get the infection with the germ. the 30%, of that you may have 5% of people that will go on to what we call early progression. Now what that means is this small group of people, and we're talking general population of people. I will talk a little more about pediatric risk factors in a moment. But let's say we have 5% of people that are infected that would go on to develop disease. Okay, well that's significant to that group of people. But on the other side, there are 95% of people who get the germ and they're infected and they contain the germ. Basically, their body contains that germ through the immune system such that, yes, they are infected, but they don't develop disease, but they could develop disease later on in life. And that's where we get the number of about a 10 or so % lifetime risk of tuberculosis in general. Now, this does not apply to patients that are extremely young. Again, pediatric patients, they can have a much higher risk of developing disease, or patients that have problems with their immune system or other issues which we will discuss later in the program. This is a general number, but there are patients that are more high risk to develop tuberculosis, and we'll talk about that. So how does TB enter the body, and how is the person infected with tuberculosis? Well, if we look at this slide, which actually came from some medical materials through CDC, if we look at this slide, again, just because a person has tuberculosis in Montgomery, Alabama, doesn't mean that I'm going to be infected with TB when I'm in Florence, Alabama. I'm not around the person, so I don't have to worry about my risk for infection with that patient. You basically have to inhale the droplet nucleus or the droplet nuclei. And these droplet nuclei, which are inhaled again through the upper respiratory tract, have to travel down through the lungs, through the trachea, and out into the alveoli. And that is really where all the action happens, is out in the alveoli, where this germ, is inhaled and the droplet nucleus sets up shop. So really, let's talk about those droplets. You think about, okay, well, just one little droplet. Again, if the droplet nucleus is inhaled and sets up shop in the macrophage, that's where we have a problem in terms of infection and then disease. Now, what are droplet nuclei? Well, droplet nuclei are infectious particles that are very small. And those of you that are nurses or physicians or have microbiologists or had medical training will know that very large droplets can be trapped in the upper airway, in the nose or in the nasopharynx. But these little droplet nuclei are fairly small, again 1 to 5 microns, and they can remain suspended in the air for several hours. And that's where the problem is. Again, if a person has tuberculosis and they are coughing and they are producing the sputum, coughing out into the air, and they're within a reasonable distance of someone who is susceptible, then the next thing you know, they're going to inhale those little droplet nuclei, and then you've got a problem. Now, Dr. Jeffrey Stark from Baylor, who is one of the preeminent pediatric physicians in tuberculosis, states in some of his literature that one droplet nuclei can contain 1 to 3 TB germs. And while if we may think, okay, that's a small number, but the reality is looking at how far do these little droplet nuclei travel, and again, a susceptible population. So that's why we have a concern. Now, when these droplet nuclei enter into the alveoli, they encounter what I call the big eaters, okay, in the immune system. The macrophages, they're big eaters, and they like to eat things up. So when this droplet nuclei is inhaled and they encounter these alveolar macrophages, well, the mycobacterium can be killed as a result of its encounter here. It can be contained, or it can progress to active disease. So that's why we have a concern, especially in people with immune system problems, because they might be much more susceptible to develop disease. And as we talked about just a moment ago, I mentioned immunity. Well, T lymphocytes. Well, we're all about those T's here. And those T lymphocytes in the immune system are very, very important for the host to be able to contain the infection. So it follows that people with reduced immune systems, such as people that might be infected with HIV, people who might have diabetes, people who might have other immune system disorders, young children, it follows that these patients are more susceptible. So again, we're all about those T's, and we're all about those T lymphocytes being involved in containing this infection. But what happens, again, we inhale the droplet nuclei, which contains the mycobacteria. And then the mycobacteria are just not satisfied to stay there in the alveoli. And other places that the mycobacteria like to go. And they like to go throughout the body. So that's where our lymphatic system plays a role. So you have lymphohematogenous spread, if you will. It's nice for those of us who treat tuberculosis if the TB is primarily pulmonary, because that's something that, you know, we're all used to. It's a little easier for us to grasp that concept. But the TB germs go other places. They go to the lymph nodes. They go to the kidneys, the bones, the meninges, and all the wrong places. So TB can affect any area of the body. And just to talk a little bit more about this, the way I like to explain to my patients infection versus disease is that the TB germ, I like to call it asleep. When the person is infected but they don't have disease, I say, you have the germ in your body, but it's asleep, and your immune system is keeping it asleep. However, with different factors, including immune system, age, perhaps even genetic factors, and other issues, this germ can wake up and cause you a problem. And that's why in some situations we offer preventive therapy. And we're going to talk about that concept a little more in a moment. Now, I'm a pediatrician, as you noticed from the introduction, and pediatricians become very, very concerned about children infected with tuberculosis, especially in a young age group, because the risk for developing TB meningitis is significant, and this is a devastating disease. So again, this TB germ is not happy just to stay in the lungs. It likes to go to other places. And in my career as a physician, my career working with tuberculosis, while we may see that about 3/4 or more of cases are pulmonary, you know, I have seen TB of the lymph nodes. Actually saw this in a child a few years ago. One of my patients early in my career was a young adolescent boy who had developed TB infection from exposure. He did not take preventive therapy. Again, this was a number of years ago. And this unfortunate young boy lost a kidney to tuberculosis when he was a teenager. So this is not something that we want to have happen to our patients. And there certainly are ways, even if people are infected, to prevent the risk of their developing disease. So who gets TB and who doesn't? Well, as we talked about, you know, that risk of people, that group of people that might have more risk in terms of their immune system or other factors. Well, certainly the more organisms a person has and is exposed to, in other words, the more infectious the case is, the more likely for there to be transmission. But it's important to know that one Mycobacterium bacillus can initiate infection, and again, the droplet nuclei can contain 1 to 3 bacilli, as Dr. Stark said. And also a susceptible host. Well, conceivably, all of us would be susceptible if we were exposed to the germ. But we're talking about degrees of susceptibility, and I will cover that as we go along. So hanging out with a TB germ is probably not the best idea that any of us have, because a TB germ in a good environment can certainly cause infection and disease. Now, if we have a small space, small rooms that don't have a lot of ventilation, let's say, for example, you know, in a home that, you know, is a small room, smaller spaces, less ventilation, closed space with less air circulation. I had a child a few years ago that had been just riding in a car with a case of tuberculosis, a person that had tuberculosis, and they would ride about 20 minutes once a week. And this child developed TB infection. Shared air. Of course, we talk about institutions such as perhaps the prison system. Shared air is important. In a situation where we might have a ship, even there's literature in the military where there have been cases of tuberculosis in people that have been on a ship together. Maybe, ship seems pretty big, but there's some small spaces, enclosed spaces, and shared air. In addition, we talk about the time, the length of exposure. How long is that person exposed to that person that has tuberculosis? Do they see them every day? Do they live in the house? Do they ride around with in the car with them? Or is it someone that they saw across the aisle at Walmart? Probably not very much risk there because, again, air circulation, large place, etc. And again, as I said, the length of exposure, how long are they with that person, the frequency of exposure. So these are all factors that when we are investigating a case of tuberculosis, we look into. Excuse me. Now, let's talk about the germ, okay? Well, all germs are probably, not exactly the same. And, of course, if we think about, well, my germ is stronger than your germ, my germ is bigger than your germ, my germ is better than your germ. Okay, if a person has tuberculosis, which people can have tuberculosis without having an extremely productive cough, or without sneezing a lot, singing, shouting, duration of symptoms, cavities, smear positive. Let's talk about that. Again, a cough. We go back to the 1 to 3 droplet nuclei in the small space, or the 1 to 3 germs in the droplet nuclei in the small space, and the person has a cough, a productive cough, where they're bringing up a lot of material. Okay, that's pretty strong risk there. Sneezing, in addition to that, as you saw the slide earlier, can really spew out a lot of droplet nuclei, a lot of organisms. There have been cases of tuberculosis transmitted in situations where persons sang in a choir or in a vocal group. So this is something of concern. We ask about these factors. How long has a person been sick with tuberculosis? And this is very significant because we as physicians and nurses, healthcare providers, we need to think about when we're talking to our patients risk factors for their having tuberculosis. In some areas of the country, we see more tuberculosis than others. In Alabama, we may have 100+ cases of tuberculosis in a year. Some states have more than us, some states have less. I believe the figure of, somewhere 4 per 100,000 population. But again, looking at tuberculosis overall, some areas of the country are more likely to have TB than others. Some areas of the world are more likely to have TB than other areas of the world. There are countries in the world that have 50% of the population infected with tuberculosis, whereas in our country, our background rate of infectivity would be pretty low. So we have to consider that these factors, again, the duration of symptoms, we know that if we as physicians and nurses don't think tuberculosis, that people might present with these pulmonary symptoms and we might say, oh, well, they have a community-acquired pneumonia, or, oh, well, they have a flare-up with their asthma, or they have allergies, or they have COPD, or they have lung cancer. And they may have COPD, and they may have lung cancer, they may have asthma, they may have a flare-up with their allergies, they may have community-acquired pneumonia. But that doesn't exclude tuberculosis. We need to think about tuberculosis, think about the risk factors. Cavitary tuberculosis, there's actually a pediatric study that indicates that persons who have a cavity and have a cavity on the right side of the lung are more at risk to transmit the disease. And as a physician, that makes sense to me because the right main stem bronchus is straighter, so there's kind of a direct path up. So cavitary disease, not just obviously in the right lung, but I thought that was an interesting study several years ago. And people who work with me know that I'm always looking at, oh, well, this study says this and this study says that. So again, something that I was interested in. And again, smear positive. Does the person who's under investigation for tuberculosis have sputum that is productive, and when we take it to the lab and we put it on a smear, the laboratory looks for the mycobacteria? Does the smear show mycobacteria on the slide? Well, when you look at this, you have to remember that your laboratorians who do this kind of work, such as our state health department laboratory, the smear has to have probably about 5,000 germs to really be able to be seen under the microscope. So, you know, it is possible for someone to have TB and be smear negative. But if they're smear positive, that is much more of a risk, because that means there are more germs there for us to see. Okay. Well, you know, my germ is better than your germ. I can get more bacteria out. You know, I can transmit more. One cough can spread 500 droplets. And remember I said 1 to 3 mycobacteria in a droplet. So it follows that there could be a lot of mycobacteria, and it only takes 1 mycobacteria. The average patient with a productive cough may produce 75,000 droplets a day prior to therapy. And these figures, as I've read these through the years, it just really amazes me. I think, my goodness, that is an awful lot of concern there. And again, the droplets may remain suspended in the air for a period of time. So we have to be very concerned about the exposure in the environment, in a small, enclosed space where the person could be close by. And again, while years ago this family told me their child had been in the car for about 20 minutes with this case, and I was hoping against hope that this child would not be infected with tuberculosis. But thinking of these figures, I thought, okay, going down the road in an enclosed car for 20 minutes and a person is coughing, that's a pretty good chance that they're going to have some exposure and infection. And indeed, the child did have infection with tuberculosis. So it follows that obviously with that number of organisms, that could happen. Well, okay, I have the biggest germ on the block. I'm the germ that comes in and, you know, I infect a lot of people. Obviously, the number of germs in the environment, as we've talked about, but the virulence of the organism. And as we have learned through the years, it's not just one population of organisms that the person may have, actually several populations in that infection. Genetics can certainly play a role. That one host, and we don't have all the information on this that we need, but some of the information indicating that some people are just more susceptible due to their genetic makeup. And also some of the newer information, because the field of genetics has become much more prominent during my career as a physician, that this plays a role in terms of the patient's ability to respond to medication. And that's very interesting to me, because there are actually some other studies that indicate, for example, some hypertension drugs that some people don't respond as well. So where we as physicians at one time might have said, I just don't think that person's taking their medicine. Well, I think now we see, even with tuberculosis, and we supervise the medicine, but there are some people that don't respond to the medicine exactly the way other people do. So again, genetics, learning a lot more. Tuberculosis, a disease that has been described for, you know, many years, but we're still learning about it. So TB. Well, TB is a contact sport. Again, you have to have contact. As I mentioned earlier, if someone has tuberculosis in Montgomery and I happen to be in my office in Florence, Alabama, I'm not going to get TB from that person, you know, just because I happen to read about it in the paper. But it's very important that we continue to educate about how TB is transmitted. Shared air, obviously, airspace is extremely important. The length of exposure, the distance to the case. You know, am I in a room, but it's a larger room with more air circulation? I'm not as close to that case. The ventilation of the area. How is the area, how's the air conditioning, how's the heating, what kind of situation do we have there, and the recirculation of air. And these are all areas that our DIS, our disease investigation staff, look into. And I'm very grateful that they do this, because I am not an environmentalist and I don't have this training. So I'm very grateful that they can come in and tell me about that environment, and tell me about the ventilation system, tell me about the shared air and the risk for that patient. So again, it's a contact sport. You have to be in contact with it in order to contract it. Okay, so we're back to who has the best germ and who's most likely to transmit. Well, we do know, obviously, that if a person has pulmonary disease or disease in the larynx, it follows from the physiology. They have to get the germ out into the environment. They have to cough to get it out, have to cough to get those little droplet nuclei out, so that those mycobacteria that are in there can then be suspended in the air in the 1 to 5 micron size. Somebody else can come along, breathe it in, and gets out there into the alveoli. Macrophages do their thing, then we see what happens. But again, pulmonary disease or laryngeal disease, obviously, transmission, pretty significant there. And again, cough, a person with a very productive cough, as opposed to a person who just has as we physicians fondly refer to, a slight dry cough, is not as significant as a productive cough. Failure to cover the cough. Now again, you saw on the introduction that I not only work with tuberculosis, but I work with immunization, so I have an interest in influenza and other respiratory illnesses. So failure to cover the cough, and we've talked a lot about cough etiquette. We do know, obviously, that people who fail to cover their cough, they're going to put more organisms out in the environment, and hence more droplet nuclei, more germs, setting up a shared airspace for people to develop disease. Okay, we talked about the positive smear. As I said, 5,000 organisms or so to have a positive smear, but that's not inconceivable with the numbers I told you. Cavitation, another factor that's pretty important. Non-compliance. I want to mention this because I know there are some social workers in the audience. In tuberculosis control, and I will stress this again later, we require that patients who have tuberculosis disease have directly observed therapy. And by that I mean we make sure that they take their medication. This is exceedingly important because tuberculosis therapy is not just 1 or 2 weeks. In a good situation, we can treat a patient in 6 months. But patients failing to take medication, TB is a slow-growing germ. And if you expose the person to medicine, they take the medicine, they decide to quit taking it for a few weeks, they move off, go somewhere else, you have a little trouble finding them. These kinds of situations set you up for what's called drug resistance. So non-compliance. If we have patients that perhaps were in another state, they were non-compliant, they moved into Alabama, we didn't know they were here, they presented to the emergency room, and they were sick with tuberculosis, again, their risk for having pretty bad tuberculosis is significant. And then we have to obviously work with what other states were involved or what other countries might have been involved getting this information. So again, non-compliance is very, very, very important. And poor clinical response. As I mentioned earlier, not only immunologic factors, but also perhaps genetic factors that might lend a person's situation to not responding as well to the drugs. But in addition to that, a poor clinical response because of a high burden of disease. So these are the patients that they really have some pretty strong germs here, and they may have the best germ of all to infect people. So what else can go wrong? Well, a lot can go wrong in situations where people have tuberculosis and we don't have them identified to us early. That's why I'm always making the case to my physician friends, my nurse friends, my nurse practitioner friends, anyone that will listen about tuberculosis, that we need to think TB. Because if we don't think TB, we're not going to diagnose TB. And I mentioned other conditions. We have to be aware of those. Well, the age of the patient, again, as I mentioned, being a pediatrician, I have a special interest in pediatric tuberculosis. And while I mentioned that overall, 10% lifetime risk, if we have a child that's infected with tuberculosis and they are under a year of age, and their risk, if they're infected, of developing disease is about 40%. And so that's why I'm very passionate about all my patients that we treat for tuberculosis. But with children, I have that extra level because they are so much more likely to develop disease, develop invasive disease, develop TB meningitis. And again, it's a very devastating illness which I unfortunately have seen in my career and would rather not have to see again as a pediatrician. We talked about the immune status. As I said, diseases that affect the immune system, such as cancer chemotherapy, such as HIV infection. And again, underlying disease. Diabetes is a good example. So all of these things can go wrong that the person's factors here make them more at risk to develop disease. Now, as I mentioned age earlier, puberty to 19 years of age, overall about a 25% risk in one study, and then the elderly have an increase in the risk for tuberculosis. When I was a young doctor, which I'm sure many of you can tell has been a number of years ago, but when I was a young doctor, one of my mentors pointed out to me some pediatric literature that indicated what we call the golden age of childhood. And what this really talked about is children up to about 4 years of age or so are more at risk if they develop infection to go ahead to disease. And then after that 4 or 5 age range up till puberty, they seem to be less at risk for disease. This is probably related to immunity. And then at puberty, again, you see a spike. So we see in our slide here, puberty to 19 years, cavitary disease. And we have seen teenagers with cavitary pulmonary tuberculosis. So again, that does not mean that children in the age group 5 to 12, 13 don't ever get tuberculosis. That's not true. They certainly can and certainly do. But if they're infected, they're less likely to go on to disease, which again is related to their immune system. Well, as we talked about the progress of the disease, about 10% of adults with LTBI, latent tuberculosis infection, which means they breathed in the germ, they got the germ in their body, they have about a 10% chance of going on developing tuberculosis. Again, 5% or so within a couple of years of the time they've actually been infected. This is why we as physicians and TB controllers, when we are first investigating a case, we want to know, okay, now when the person got infected, we want to be able to tell them, well, your risk of developing disease within the first couple of years after being infected is this number. Again, but if it's you developing disease, it's 100% for you. And then the 5% risk over the lifetime. But we have to remember that people can remain infected and not develop disease. And I want to talk about medical conditions more specifically. I've mentioned HIV infection because our population of patients who are HIV infected are very high risk if they develop TB infection to go on to disease. And this is why we really stress if we have an HIV patient that presents to us that has been exposed to tuberculosis and has just developed a positive skin test or a positive IGRA blood test for TB, to go ahead and put the HIV patients on preventive medicine to reduce their risk of developing TB. This is very important to this population of patients. In addition, organ transplant patients, well, it follows why are organ transplant patients more at risk? Because of medications, immunosuppressive drugs that they have to take in order for the transplant to be successful. Silicosis, and again, in my early training as a physician, when I was in medical school, we saw a lot of this related to industrial work, silicosis and TB co-infection. Diabetes, obviously, we know that affects the immune system. And again, the TNF agents that now are being used in immunologic diseases, for example, such as Crohn's disease, such as juvenile rheumatoid arthritis. I mean, these are very important drugs. And physicians that are working with patients such as rheumatologists or gastroenterologists, I know you've seen advertisements on TV for these drugs. It's very important physicians working with these patients be aware of a risk for tuberculosis. It's actually mentioned in one of the commercials of one of the agents, so that they can adequately screen and put patients on preventive TB medicine if necessary, if they truly have been exposed to TB, and follow up. And of course, high-dose steroids, which will do the same thing, reduce the immune system activity. Other diseases, chronic kidney disease, renal failure, some cancers, gastrectomy, where part of the stomach is removed. Of course, people who may have an abnormal chest x-ray may have another underlying pulmonary situation. And people with low body weight are at increase overall to develop tuberculosis. As I mentioned earlier, TB is a social disease with medical aspects. And I think it's extremely important that we recognize in our population of patients that these factors can contribute significantly to a person's ability to comply with therapy and respond to therapy. A good example, if a person has a substance abuse issue, it's very much a risk factor, not only for developing TB, because they might be in a population where there are more people in a small environment, exposure, we go back to our droplet nuclei once again. But in addition to that, perhaps not taking the care of their health that they need to. So again, substance abuse can be very significant. I mentioned foreign-born. The foreign-born population of patients, certain countries in the world have higher burdens of disease, higher burdens of tuberculosis than the United States. Just some areas of the world who have higher burdens, for example, in Southeast Asia, there's more burden of tuberculosis, more burden of tuberculosis in Central and South America, more burden of tuberculosis in certain parts of Africa, and also Eastern Europe and the former Soviet bloc. And these are just some areas of the world. And we live in a global society where people might be coming to the United States for educational opportunities, economic opportunities, to visit family members. And we have had cases of people who come here for whatever, again, those specific opportunities and have tuberculosis. They become ill and they develop tuberculosis, and again, higher risk of disease overall. This is why we go back to thinking about, as a physician, as a nurse practitioner, teasing out that history. You know, a person presents to you with a cough, productive sputum. Okay, are they a foreign-born person? Are they from a high-risk country? How long have they been sick? What have their symptoms been? Have they had fever, cough, night sweats, chills, weight loss, chest pain? I mean, these are certainly symptoms that can occur with regular garden variety pneumonia, as we pediatricians like to call it, but it can occur with tuberculosis. So we want to make sure we think tuberculosis. Homeless population, again, sets up its own risk factors and its own problems, because people who do not have a place to go, do not have a place to get proper nutrition, do not have a place to, have a clean, healthy, safe environment. So a homeless population, more at risk. And again, these social factors do not travel alone. We may have a person who is a homeless person who also has a substance abuse issue. So we have to be aware of these. And poor social support. And we encounter in our patients, again, as a pediatrician myself, I encounter a broad array of patients and children that have very privileged and advantaged backgrounds, as opposed to children who do not have the opportunities, do not have the social support. Perhaps they have only one caregiver in the home, only one parent in the home, or the parent may not have a job, or they may not be able to provide for that child. So overall, a poor social support environment. I mentioned children because, that obviously is a special interest for me, but certainly this can occur in the adult population as well. So again, TB is a social disease with medical aspects. Now, when we're talking about TB, it's an important concept that we differentiate from infection and disease. And this is a concept that I work very hard with my patients and our TB disease control staff here in the state of Alabama, I think are unlike any other in helping patients to understand the difference in this concept. It's very important for people to know infection means this and disease means this. This can be a very emotional situation when we have a case of TB in an institution, when we have it in a school setting. Excuse me. It's going to be a very, very emotional thing because, I have children. They're grown now. But we as parents or as caregivers, grandparents, friends, neighbors, aunts, uncles, we want everybody to be healthy that are around our kids. We want to protect our kids. So it can be very emotional if someone knows that there's someone in a school that has tuberculosis. And next week in our next session, we will talk about the investigative process in that type of environment. So again, we want to make sure people understand the difference between infection versus disease, because there's the opportunity, first of all, with infection, there's this opportunity that we as TB controllers, in partnership with our patients, can reduce their risk of developing disease. And then there's also the opportunity to educate so that people know about tuberculosis. Is tuberculosis contagious? Well, absolutely, it is. And we talked about some of the factors for that. But also to alleviate some fear that the public might have. And I believe, having worked in public health for a number of years, that if we provide people with education and information, then we empower them to go out and make good decisions for themselves and good decisions for their community. But we have to provide this information, and we have to provide it on a regular basis, because if it's not something that they're working with every day, like we live in the TB world ourselves, we deal with this every day. People don't have these answers if they don't do it all the time like we do. So let's talk about infectious versus disease and a little bit of what I call detective work. The medical history. As a young student myself, I had the privilege of being trained by a physician, Dr. Tinsley Harrison. And those of you that are physicians, nurses, nurse practitioners may have seen a book called Harrison's Principles of Internal Medicine. Dr. Tinsley Harrison, a very famous doctor at the University of Alabama and a University of Alabama School of Medicine. And again, I had the very great privilege of making rounds at the VA hospital in Birmingham many years ago with Dr. Harrison. And he emphasized the medical history. When you go in to talk to your doctor or your nurse practitioner, finding out the information is extremely important. You want to know how long that patient's been sick, what the symptoms the patient has, how long have these symptoms been going on, have they encountered any environmental risk factors, international travel, being around someone that may have had TB. Now, hopefully, in an investigation, we've picked this up, but there may be times that we don't get all the information that, a person has been around TB. So it's very, very important to seek this information in the medical history. And again, Dr. Harrison had a great influence on me in being very aware of taking a good medical history. In addition, skin test or IGRA. And we're going to talk a little more about this, but just to mention, I think most people are very familiar with, whenever I say skin test, I tend to do this because this is where we place the skin test. So whenever I'm speaking of a patient about skin test, I'll do this. I'll just immediately put my right hand on my left forearm and say skin test. And many people are familiar with having the injection, the little bubble placed on their arm, and this is a TB skin test. Well, this is an old test, and it may be hard for you to believe the test is older than me, but it is. It's an old test, and it's a good test. However, we are very fortunate that with the development of more information about tuberculosis, we now have a blood test called the interferon gamma release assay, which has been shortened to IGRA for people like me who tend to have a little trouble saying it. But the interferon gamma release assay. Now this test really I like very much, and I like to use the IGRA, and there are populations that the IGRA is very, very useful for. There are populations that we might still use the skin test, but I really like the IGRA. The skin test basically uses the purified protein derivative, uses an antigen. We put the skin test on the arm. It has to be replaced by someone who has experience doing skin tests, erstwhile we in the health department consider it to be very important that physicians, nurse practitioners, that offices are trained on doing a proper skin test, because you get the needle too deep, you get the needle too shallow, not going to have a good test. And then we have to wait 48 hours to see whether or not that test turns red, but more importantly is a bubble with what we call induration. And I always tell people, I really don't count redness. As a physician who's read a lot of skin tests, when I look at the person's arm, the first thing I do is close my eyes. I look at the arm and then I close my eyes, because I'm not really looking at that redness. You know, redness happens and it's kind of useful to know that it's there, but then the next thing I want to do is I want to touch that skin test, and I want to rub that skin test, and I want to take perhaps an ink pen and see how wide that induration is, how broad that induration is, so that I can correctly measure that skin test. Because the measure of the skin test, which is not something we're going to talk about today, but there are cut points on the size of the skin test. And again, nurses, doctors, nurse practitioners that are familiar with this will know what I'm talking about with cut points. The IGRA, the interferon gamma release assay, is a blood test. And while the skin test, we have that done 48 to 72 hours later, the patient has to trudge back and let us look at it. With the IGRA, we can draw the blood, we can send it to the laboratories. This is a specialized test, a specialized laboratory. And the IGRA really measures the white cells that have been infected with the tuberculosis. Will actually have some antigen in there, and it will show positive or negative on the test. Now again, that's a very, very general description of IGRA. I hope there aren't any infectious disease doctors on the phone call, but or on the webinar today. But the IGRA basically, in my way of thinking, draw the blood, send it to the lab. We get a positive or negative. We can get an indeterminate, but usually a positive or negative. And that's very, very helpful to us to determine if the person has been infected with TB. And we don't have to have them come back and have us read the skin test in 48 to 72 hours. So I like the IGRA. Now the drawbacks with the IGRA, for me as a pediatrician, the drawback is that it's really not been well studied in children under 2 years of age. So we're still left with doing skin tests in that group. And the IGRA is more expensive. I'm hoping that with more use that it will become less expensive for us to do more IGRAs. But I really like the IGRA. I think you all have probably discerned that, so I'll move on to the next point. Chest x-rays. Again, very important. A person presents to us with a medical history that could be at risk for tuberculosis. We do a skin test or an IGRA. We don't do the chest x-ray. We'll probably do it the same day right there, or the next day, just as soon as we can get that done. And a quality chest x-ray is important. Again, I am a pediatrician, so I emphasize making sure that we have our chest x-rays done so that we actually have a good film that we can read. The problem is that any of you who've ever had your child have to get a chest x-ray, for some reason 1-year-old children do not enjoy this, and it's very hard to tell them to take a deep breath and hold it. So it's a little bit of a trick to get good chest x-rays on children. Certainly can be done, but it does require a little special extra added attention. The physical examination, again, as clinically indicated, we mentioned we have a person who presents with pulmonary disease. For example, we're going to listen to the chest, percuss the chest, thump the chest, if you will, listen to the heart, see what's going on in terms of physical examination. And also sputums. Again, all of this comes together to help us determine if that person has tuberculosis or have they been infected with the germ, but they don't have any disease. Sputums are important, as I mentioned. I think it's something we in TB go around all the time saying sputums for AFB times 3, which basically means getting a sputum on 3 consecutive days, every morning for 3 days. Morning specimens, much better because the person has been asleep all night, hopefully, and they have more material that they can cough up. Again, I'm a pediatrician. Hard to get sputums on young children, maybe indications at times for us to do other procedures in children. Well, that's outside the scope of our discussion today. I mentioned the skin test and the IGRA, and we'll have a moment to stop shortly. I think this might be a good stopping point shortly after this. How long does it take for that skin test to turn positive or for that IGRA to be positive? Well, after the exposure to the person who has tuberculosis, the person who has been exposed, who is a contact to the case of tuberculosis, it takes 2 to 10 weeks for the immune system to respond. So if we do a skin test at the time that we're doing the investigation and that skin test is negative, or if we draw an IGRA and that IGRA is negative, then with that population of patients, we're going to go back and wait 10 weeks to rescreen. If that person is a contact and is at risk to develop tuberculosis, then we're going to go back and rescreen with our TB skin test or our IGRA because we want to give the immune system the opportunity to respond. Now, I mentioned being a pediatrician, and I'm sure y'all are probably tired of hearing that, but you'll hear it at least for another hour after this. In children, if a child is a very young child, basically 0 to 16 weeks, doing a skin test is something we do if we have an exposure, but the immune system probably cannot mount a good response for at least 16 weeks after birth. So we as pediatricians tend to be more on the end of repeating that skin test not at 10 weeks after the exposure has stopped, but around 16 or so weeks. And again, 16 weeks being about 4.5 months or so, and maybe even up to 6 months, depending on the exposure. And again, we pediatricians are very, very concerned specifically about the exposure in that age group. As I said earlier about the immunity, the development of the positive skin test or the positive IGRA relates to the cellular immunity, the cellular hypersensitivity, those T cells. We're all about those T cells, and that's what really this relates to. I think we have reached a good stopping point for a 15-minute break before I talk about latent tuberculosis infection versus tuberculosis disease. Thank you for participating in our first hour, and we'll see you in about 15 minutes. Thank you very much for joining us again for the second hour of Tuberculosis 101 for Disease Control staff. We appreciate the opportunity to be able to speak with you and to provide education on this important topic. I mentioned latent tuberculosis infection and disease, and this is an extremely important concept, as I said earlier, not only for the patient but also for the general public, as well as those of us who practice in the medical field. We want to be able to comfortably and confidently convey this information to the patients regarding this. So let's talk about LTBI, latent tuberculosis infection, and then we'll talk about disease. Latent tuberculosis infection means that the person doesn't have symptoms of TB. First of all, they are not coughing, they do not have weight loss, they have not had chest pain, they have not had night sweats, they have not had fever. All of the symptoms that we talked about and more. They're not sick. LTBI, they're not sick. They don't appear to be sick. Their TST, TB skin test, or their IGRA is usually positive. Now let me say usually positive because we can have an LTBI, a person that has been exposed to TB, they have no symptoms, and their skin test hasn't had time to convert. As I mentioned, that 2 to 10 weeks, but also in the pediatric age group, in a very young child, could be up to 16 weeks or so in a child from 0 to 16 weeks of age. So we have to be cautious in that population. The chest x-ray, a very important concept. If you're an LTBI, your chest x-ray is normal. That means your chest x-ray is normal. If there are abnormalities on your chest x-ray, then that needs to be evaluated. A person may have LTBI and have some other reason to have a problem on their chest x-ray, which would be teased out in the evaluation, but we want to make sure that they have a normal chest x-ray or some other reason that might account for some problem on their chest x-ray. And sputums, if indicated, and we don't always do sputums in an LTBI. For example, I mentioned children. We're not going to have a 8-year-old child who's been exposed to tuberculosis who has a positive IGRA and a normal chest x-ray. An 8-year-old child is probably not going to be able to give us sputums. And again, as I mentioned, in a very young age group child, depending on the evaluation, we might need to do other procedures, but not generally if we believe that this is LTBI based upon our history, our physical assessment, our skin test, our chest x-ray, and in our adults, our sputums. So again, let's talk about disease versus LTBI. And again, a very important concept, and not a concept that is just easily adopted if you don't live in the TB world every day like we do, but something that if you look at the parameters and look at the factors, you can see the difference. TB disease, as I mentioned, these patients are symptomatic. They may have multiple symptoms: fever, cough, weight loss, night sweat, productive sputum, chills, blood in the sputum, hemoptysis, chest pain, fatigue, anorexia, weight loss. These are all symptoms that can accompany tuberculosis. And again, I'm talking primarily about pulmonary tuberculosis here. We can have extrapulmonary, and I will talk about that in a minute, and a person may have symptoms referable to that organ system. For example, if someone had TB of the kidney, they may have blood in the urine, they may have white cells in the urine, they may have other symptoms which would be of concern. A person that has lymph node TB would have perhaps a very enlarged lymph node. A person that has bone TB could have abnormalities on their MRI or their spinal x-ray, something of that nature. So again, right here I'm primarily talking about pulmonary tuberculosis because other organ systems can be involved. Again, I mentioned that most TB is pulmonary, but not always. Meningitis, for example, a child may present with severe symptoms, fever, obtundation, seizures. This is something that we all hope we never see, that we identify the TB early, we identify the exposure early, and we evaluate the situation and treat that patient so that we don't see TB meningitis. Again, a very, very devastating disease. And TB disease, I mentioned the TB skin test or the IGRA is usually positive. There can be situations, and again, in children sometimes up to a quarter of those children who might have TB disease, not necessarily in a young age group, but in a little bit older, and they present with TB depending on their burden of disease, how long they've been sick, and if they're very sick, their immune system may not initially be able to respond with a positive skin test or a positive IGRA. So if a person has symptoms compatible with TB, findings compatible with TB, chest x-ray abnormal or other organ systems abnormal or other materials, for example, that have been submitted, for example, pathology, biopsy of a lymph node, something of that nature, if that's all compatible with TB, don't get hung up on a negative skin test and a negative IGRA, because that may be negative initially, and then actually have had patients that we treated for TB, and during the course of the illness, we went back and did a skin test or an IGRA, and because they were getting better with their disease, and their immune system was responding more effectively, we were able to see a positive skin test or a positive IGRA. So don't get hung up on that, and I always caution my physician colleagues, nurses and nurse practitioners, don't get hung up on one test when you're looking at TB. You've got to look at a spectrum here. In addition, chest x-ray, pulmonary, it's usually abnormal. You know, there's, again, are degrees of that. For example, we may have a person who has what we as physicians refer to as a patchy infiltrate, or we may have a person who has a cavity on their x-ray. And a cavity, for those of you that are not healthcare professionals, is basically a spot on the x-ray that looks like a hole in the lung or multiple holes in the lung. So you actually could see an area, for example, in the upper part of the chest, which is usually where we see this on an x-ray, that you will see almost a whitish material on the x-ray, and then in the center of that, a black spot. So again, a cavity or multiple cavities. We use the term cavitary TB. Again, cavitary being more infectious, more contagious. And sputum smears usually smear and culture positive, but not always. Again, we're not going to talk specifically about case definition today of tuberculosis. So, you know, just to make you aware that TB can be diagnosed with other parameters such as symptoms, positive or negative skin test, abnormal chest x-ray, and the sputums and smear may remain negative. But if they clinically improve on treatment, they can be diagnosed as a clinical case. And that gets into where we deal with what we call the case definitions. Now, this is not terribly common, but it does happen sometimes in TB control. And as I mentioned, the smear takes about 5,000 germs to be able to see this on the smear. Culture, you know, takes about 10 or so organisms to grow it on the culture. And the TB germ, I'm not a laboratorian, but I will say that we have one of the finest laboratories here in Alabama, and I'm very impressed with our TB staff there. And, you know, TB just can be a little ticky as a germ, for lack of a better word, and it takes a while to grow. It's just a little stubborn, so we have to be aware that sometimes we may not recover the organism, specifically in pediatrics, because we may have children with a lower burden of organism, even though they have disease. Even if they have pulmonary disease, we might not get the organisms out of the lungs just because, again, they don't cough up sputum very well. And while one test that we have used, kind of a time-honored test in pediatrics evaluating for tuberculosis, what's called a gastric aspirate, which is an early morning test where we pass an NG tube into the stomach, aspirate out the material, do smear and culture. The yield on a gastric aspirate in children with pulmonary disease can be maybe 20-30%, so it's pretty low. But it is a test that we do use in pediatrics. And then there are times where, if the clinical situation warrants, a child may undergo bronchoscopy. Of course, an adult may undergo bronchoscopy too, but again, these are outside the scope of what we're talking about today, other than just to make you aware that those tests might be done and might need to be assessed based upon the clinical situation. Now again, infectious versus non-infectious, and I really want to drill down on this point. LTBI, and I mentioned, and I like to say in talks, I've worked for TB control in various capacities, developed my interest in TB as a young medical student. So I've been around the medical field for a long time, 37 plus years. I'm in my 38th year as a physician, and I've worked in TB a lot, and I have a negative TB skin test. So even though I've been around a lot of TB, I've been around a lot of infectious cases, I spent a little time out at National Jewish in Denver, Colorado a number of years ago, and worked around TB in many capacities as a physician and also working in investigation and disease control. And I've never developed positive skin tests, so I've never developed infection. So with proper infection control measures, once a person is diagnosed with TB, we as healthcare providers do need to protect ourselves, and that's going to be something that's talked about a little more in the section next week, so be sure to join us for that. So to mention to you latent tuberculosis infection, I've been around a lot of TB, and I've never developed LTBI. But people who have LTBI, latent tuberculosis infection, again, we go back to one of my initial slides that showed that TB is inhaled, and it, as we talked about, the places you'll go. It can go a lot of places in the body, and it can go to sleep. The germ can go to sleep and not be reactivated, and that's what we really want it to do. But it's very important to know that patients with LTBI cannot spread TB to other people. And I deal with this when I have situations where children in a school setting might have been exposed to a parent at home, and the child is on TB medicine to prevent TB. And someone finds out that they've been around someone with TB, and they don't want to play with the child, and they don't want the child to come to school, and they don't want the child to be around their children. And this is really unfortunate, because this child with LTBI who's been infected with TB cannot spread this to other people. So we work very hard in TB control to educate, and of course that goes to confidentiality. We're not going to reveal that information, but we are aware that sometimes information through families talking or social contacts talking, people in the community might find out, and we get lots of questions about this. And so I reassure our school principals and our school superintendents that call me about this, and our school nurses, they just want to know. They're educated about it, they're fine, they just want to know, they want to be able to protect their children in the school, and they have an obligation to do that. So LTBI, you can't spread the TB bacteria to other people. With LTBI, and again, we're not going to talk specifically about preventive therapy except to remind people that when a person is infected with TB, we have an opportunity to prevent disease by providing a medication for a period of time, depending on the clinical situation. Again, in pediatrics, isoniazid for a period of 9 months. I don't use as much rifampin. There's not a drug resistance. Don't really have to do that. Or in an adult, isoniazid for 6 months. These are the fairly common LTBI regimens, the one we use most of the time. So again, an opportunity to prevent disease. Now, we'll talk about TB disease for a moment. Excuse me. TB disease, we may spread the bacteria to other, we may spread the bacteria to other people. We need treatment with a proper protocol to render the patient non-infectious and to cure the disease. And again, I mention a proper protocol. TB treatment, there's a significant amount of information through various expert bodies, the American Thoracic Society, the American Academy of Pediatrics, the Centers for Disease Control in Atlanta. There's international information on tuberculosis. There are 4 centers of excellence in the United States that all provide a wealth of information on how to treat tuberculosis. We have protocols that we follow that prescribe specific treatment for the patient. We have parameters to render the patients non-infectious, which means they have TB, but they've taken a certain amount of medicine, their sputums are negative, and they're not spreading the TB to other people. And then how long do we treat them to cure the patient? Well, again, hopefully we can treat many of these patients for tuberculosis disease in a period of 6 months. And again, next week we will talk a little more about our role as healthcare providers, as social service providers, making sure that we protect ourselves when we're taking care of a patient with TB disease. And I don't want to minimize that TB can be spread from one person to the next, but I do, again, want to go back to, I've worked TB for almost 38 years, and I have a negative skin test. And again, I've been involved in a lot of TB, so I think we have to look at that. I've had physicians tell me that who have worked in centers of excellence that they have never developed TB. They took proper infection control precautions, which many of you that are out in the audience, infection control nurses and practitioners, will be aware of those guidelines for that. I want to mention HIV because HIV and TB is double trouble. Again, we have a disease that affects the immune system, that it affects those T cells, which we're all about, those T cells. We really like those T cells. And T cells are very important in TB to reduce the risk of a person developing disease. But again, double trouble. So a person that has LTBI, they're infected with HIV, the immune system is weak. So we have a lot of factors here to consider that they may go on to develop disease. A person with HIV infection that develops tuberculosis can more rapidly develop TB disease. And the risk of developing tuberculosis, as opposed to that lifetime percentage that I gave you, is somewhere between 7 and 10% per year. So that's very significant for our patient population with HIV. So we want to protect those patients. We want to make sure that, first of all, when people are diagnosed with HIV, that their TB status is assessed, whether or not they might be infected with TB. They might have latent tuberculosis infection from a number of years ago. We want to assess those patients. So our infectious disease colleagues that work in HIV are very knowledgeable about the extreme importance of also assessing tuberculosis status for these patients, so we can give them preventive therapy, which is longer than standard preventive therapy. Well, let's talk about how TB may be just, a little bit different sometimes and kind of be a little tricky, and that's why I remind our physicians and nurses and nurse practitioners who don't live in the TB world every day to feel free to contact us. Contact your local county health department. There are people in your local county health department that have a lot of information in tuberculosis. They also can refer you to their area staff for TB control, and also to those of us who work at the state level in TB. In Alabama, we have a TB advisory committee, medical TB advisory committee, with some very, very well-known people who have experience in tuberculosis and work in tuberculosis clinically. We have pulmonologists and infectious disease physicians on our advisory committee who have the experience to be able to guide us in our management of the tuberculosis patients. So let's talk about some clinical factors which I find important as a physician. As I mentioned earlier in TB disease, don't get hung up on that PPD and that IGRA. If you've got other clinical factors and those tests are negative, don't say, well, they can't have TB because their skin test is negative or their IGRA is negative, because they can. So, don't get hung up on that one test. The abnormal chest x-ray, again, or other radiologic study or other diseases, other abnormalities in other parts of the body. For example, I mentioned a meningitis. I mentioned, that we could have renal TB. I mentioned a lymph node TB. We had a person who had TB of the fallopian tubes. So it can go other places. It's much less common, but it can go there. Other places the TB germ can go. We also have to remember, as I said earlier, patient may be smear positive if they have pulmonary TB. They may be smear negative. We have to be aware of that. And they may have a positive culture, but we do have our clinical cases where a person is suspected to have TB. They are started on preventive therapy, they're started on protocol, they're started on therapy 1. They improve on what we call therapy 1. And even though their culture is negative, with their improvement of their chest x-ray and their clinical symptomatology, they may meet our case definition as a clinical case. And these are situations where a pulmonologist and or an infectious disease doctor may be involved. We get phone calls with these kinds of cases because if it's a case of TB, we're supposed to know about it. Okay, this is not something that everyone treats in his or her private offices without consultation and involvement of the Alabama Department of Public Health. We have to be involved in management of tuberculosis patients. Now I want to talk about a NAT. I always say that NAT is really important to me. We have a test now called the nucleic acid amplification test, or that NAT, a NAT. And it is becoming and has become a very, very useful tool for those of us who work TB control, because as I mentioned to you earlier, the TB germ is ticky and it likes to take a while to grow. It takes 6 weeks to report that culture out finally as being positive or negative. Yes, we're going to have some growth earlier. We're going to do DNA probe. There's a lot of stuff that laboratory people do, and they're excellent and they provide us with so much information that we can apply to the patient. But the nucleic acid amplification test can be done on the sputum or on pulmonary specimens such as a bronchial wash. And the nucleic acid amplification test is so sensitive that about 130 germs, which is what our laboratory has told me, in that specimen, that's a tiny amount. Remember I talked about our smear. That if that NAAT is positive, if they were smear positive and they have a positive NAAT, well, you can just take that to the bank. They've got tuberculosis. We do have some germs that are cousins to the TB germ that like to masquerade around pretending that they're TB sometimes, the non-tuberculous mycobacteria. And sometimes they'll give us a smear positive and we'll think, okay, all right, we got a smear positive here, pulmonary disease, but then the NAAT is negative. Well, they're unlikely to be a tuberculosis. So I really like that NAT, and it's really helpful to me, and it's useful on pulmonary specimens. But again, a very, very helpful test, the nucleic acid amplification test. We have had situations with a very small amount of organisms where we've had a positive nucleic acid amplification test, but we weren't able to grow the germ. But again, you can take that NAT to the bank. They have tuberculosis if it's positive. I mentioned earlier pulmonary tuberculosis, and that's what most physicians are most familiar with because TB is more likely to be pulmonary. But there can be extrapulmonary disease, and I mentioned other parts of the body. That's what we mean by extrapulmonary. And the places that those TB germs will go, well, they'll go to a lot of places. Generally, people who have TB outside the lungs are not contagious to other people except if they have laryngeal TB. Again, remember where the larynx is, laryngeal TB, or if there is an aerosolization situation, for example, in an autopsy or a surgical procedure. Of course, people would be using their personal protective equipment, but there is a risk of aerosolization if during a procedure this can happen. So extrapulmonary is not generally considered to be contagious unless it's laryngeal or there could be a risk for aerosolization. So if all goes well, I'm just going to throw out a little bit about treatment in the few minutes that we have left prior to taking some questions. If all goes well with TB, which we like for it to go well, then we can use a 4-drug regimen, a standard 4-drug regimen, isoniazid, rifampin, PZA, and EMB. use those 4 drugs for 2 months. We have specific numbers of doses. We count those doses. We want to make sure we have those doses in. And then we drop off that EMB if the drug is sensitive. And then isoniazid and rifampin for the remaining 4 months, the total of 6 months. And again, the 4-drug regimen, usually we're using isoniazid, rifampin, PZA, EMB. We may drop off that EMB as soon as we know the germ is sensitive to the isoniazid, rifampin, and PZA. But we're going to use that isoniazid, rifampin, PZA for 2 months. And again, there can be some nuances in clinical treatment depending on the patient response, how quickly their sputum converts to negative, other clinical factors. There can be some nuances, but this is the basics of standard 4-drug therapy. Well, when is a person not contagious? And we're going to talk again about some infection control next week, so that if persons are doing home visiting or something of that nature, they may need to protect themselves with the patient for a period of time. So when is a person not contagious? Well, in general, when they're on an adequate protocol regimen with appropriate drugs, and they have good clinical response, and they have 3 negative sputum smears on different days. And again, I can't say it's the last time I'll say it, but I'll say it again. I am a pediatrician, right? Okay. Children with pulmonary tuberculosis are not as contagious, first of all, because of a burden of disease. It's very small, and not generally considered to be contagious. Okay, now that doesn't mean if we have a teenager that's cavitary, they're contagious, right? Okay, but if we have a 6-month-old with pulmonary TB, stop and think, that child does not have the cough, volume, the burden of disease to be able to get those famous droplet nuclei out into the air. So that is an important concept in dealing with children. I won't say there is 100%, but children are generally not considered to be contagious, except for, as I said, we might have adolescents that would have pulmonary disease, sort of an adult-like disease, even if they're not cavitary. If they have adult-type tuberculosis, yes, they have the cough volume. They can spray out those droplet nuclei. I'm talking more about the younger children. That's just something that we have to be aware of in management. And again, we're not getting sputum smears on children, so we rely on the adequate regimen and the good clinical response with those children. Again, adolescents, we're almost handling those as though they were adults. And again, older children, it would be in a situation where we as pediatricians and pediatric infectious disease specialists would be advising our TB staff regarding infectivity. Again, the children got the TB from somebody else. Now, sometimes our TB germs don't like the medicine. They don't like the regular stuff, so they like to go with the multi-drug resistant and all that jazz. And unfortunately, we deal with these germs that are not sensitive to the standard regimen. Now, how do we get to multi-drug resistance? Well, that's a whole talk in and of itself, and I'll promise to do a 3rd hour, Pam, at some point. But multi-drug resistance, there are factors related to that. One factor is non-compliance, and we try to mitigate that. Another factor is previous treatment, perhaps in another area, another country. I mean, there are lots of concerns about multi-drug resistance. What does that really mean? Multi-drug resistance means resistant to isoniazid and rifampin, and this requires us to deviate from our standard protocol. This is something that we have to look at our standard protocol and adjust those medicines based upon the expert advice of a pulmonary doctor or an infectious disease doctor that is familiar with treating tuberculosis. And sometimes, rarely, and we're not having a problem with this in Alabama, for which we're very grateful, but in the world, and sometimes in cases that might be seen in for example, centers of excellence, the germs just don't like anything at all, okay? They're extensively drug resistant. And this is a germ that I fear. I fear this extensively drug resistant germ because, as I mentioned, TB is a slow grower. likes to hang around for a while. And so that's why it takes so long to treat it. So if we have a multi-drug resistant organism plus resistant to one of the fluoroquinolone drugs and to at least one of the injectable drugs, amikacin, kanamycin, capreomycin, that organism is multi-drug resistant, extensively drug resistant. And it's a real bear to treat. It's a really significant situation. This is not something that is managed by one person. This is something that is managed by a team. Again, physicians who are extremely familiar with tuberculosis control, pulmonologists, infectious disease physicians, pharmacists being involved, nurses being involved, disease intervention specialists being involved, TB control. It really takes a lot to be involved with an extensively drug-resistant case. And the treatment time is very long. The regimen is very expensive. It is just a situation which we need to try to avoid. And that's why we in TB control, that's why we're having this course. We're passionate about TB. We're diligent about TB. We want to get that person treated, have them have a good outcome, and not see them again in this kind of situation. This is why we are so persistent about directly observed therapy. Well, sometimes we don't like anything at all. As I said, very challenging, extended length of time. This is not something that I want to be dealing with as a TB controller. Our concerns about multi-drug resistant, as I mentioned earlier, if you're previously treated for TB and you break down, that increases your risk. A foreign-born person from a country with an increased risk, and there's a lot of information from the World Health Organization related to multi-drug resistant. And again, persons who have poor response to standard 4-drug therapy could be multi-drug resistant. We have situations where we might consider multi-drug resistance based upon the epidemiology, and we might actually start people on more than the 4-drug regimen. We're very fortunate, as I said, in Alabama to have some of the preeminent experts in tuberculosis control who can advise us regarding additional regimens outside the standard 4-drug regimen. Again, patients that are exposed to multi-drug resistant, they're at increased risk to develop multi-drug resistant. And the HIV positive patients, we have to be concerned about them. Extensively drug resistant, as I mentioned, it's another talk, and we really, really need to try to avoid extensively drug resistant TB by being diligent in our investigation, diligent in our management, diligent in our directly observed therapy, so that we can avoid dealing with this organism. As I talked about HIV already earlier. Now, TB management and treatment is a journey. And I tell all my patients, again, when I start to deal with my young children who are TB disease or their families, that, you know, they may not like me very much when we start out, and they're probably not going to like me at all at the end of therapy. Or they may like me when they start out, they may love me at the end of therapy. But what's important there is with TB, again, it's a social disease with medical aspects. And we as TB controllers have to develop a relationship with our patients, which I think is unlike other diseases that I have treated or encountered as a physician. Now, people may argue, well, yes, you have diabetes control, yes, you have hypertension, but there are so many other nuances in treating TB that I submit to you that it's unlike anything else, and we have to develop that relationship so that we can go on this journey with our patients and have the best outcome possible. TB is treatable, that's what I tell people, but I also say we've got one shot at getting it right. So when we start out, we're going to start that relationship. We're going to treat that patient. We're going to do directly observed therapy. We're not going to have lapses in therapy. We're not hopefully going to move to another state without our being able to coordinate and notify, or move to another country without our coordinating and notifying. I just tell my patients, just stay with me until you get through with treatment, and then you can move. And I actually had a child that we were treating that was under a year of age, and I really just convinced the family just to delay their move to another country until we got finished. Let's just, just stay with me. Just let us get finished here in Alabama. It's just simpler than having patients moving to other places in other states, and knowing that other states we coordinate all the time with, and they're doing the same thing we are, and they're dealing with that same journey. But once we have the patients, we just like for them to stay with us till we get our treatment done, and I feel like our other colleagues in other states feel the same. Let us finish your treatment. The treatment varies. Again, we're hopeful for the 6 months, and if the patient's clinical status responds, then we'll get you through in the 6 months, and I'm happy with that as a physician myself. But if the person has other factors, we may have to go longer. And so we try to give a good idea when they start out how long it's going to be, because it's a journey, and it's not something they're going to just see me about one time and then come back in a year. No, they're going to be seeing me as a child, as a pediatric patient. They'll be seeing me for a while. Compliance with the regimen and the close monitoring, I can't say enough about directly observed therapy. I mean, it is the standard. In Alabama, we are committed to this standard of directly observed therapy. And this is to ensure that our patients complete medication. I mean, I think most people want to get well, but let's think about ourselves. Okay, if we had to take a medicine every day, we had to take multiple medicines every day, well, how likely is it that we're going to miss a medication? I think there's studies to say that, the compliance, like 30% of people aren't going to take their medicine at all, even if the doctor prescribes it. I might have a little higher compliance in children, but I can treat children with ear infection. They come back to see me, and the parent has half a bottle of antibiotic left. Well, why did they stop the antibiotic? Oh, they started feeling better. Well, the same thing happens with TB. We treat you for a period of time, and you get to feeling better. Well, you're not cured of TB, but you're feeling better. So I really don't want to take that handful of pills. I really don't want to do that. So that's why it's very important for us to have compliance and DOT. Now, that's the end of my presentation in terms of slides, and I think we have about 15 minutes left. If anyone would like to ask any questions, or if we have any call-in questions or internet questions, I would be happy to entertain those. Again, this is part of a series. We're going to talk today about the basics of TB, and next week we're going to talk about infection control as well as investigation of tuberculosis. So let me stop and ask if anyone has any questions.
Dr. Flanders, I have a question.
Yes.
With a patient who has active TB or infectious TB, can that be passed in utero, a pregnant patient?
It is possible. It is possible. Congenital tuberculosis, again, that's another one of those talks that may be done for the future. But yes, congenital tuberculosis can happen. If we have a mother with tuberculosis, it's incumbent upon us to work with the specialists who deal with tuberculosis as well as her OBGYN in order to properly manage her during pregnancy. But if we have a mother with TB and when the child is born, there may be times, depending on if the mother is very recently diagnosed right before delivery, that the infant might need to be separated from the mother for a period of time until the mother is rendered non-infectious. And we actually dealt with a situation of that nature, Pam, here in Alabama back in the summer. So, yes, we do have situations like that. So, yes, thank you for that question. Other questions that I can answer?
I did have one more question.
Sure.
You mentioned the IGRA, and why is that not the standard testing since it's more accurate? Is that right?
Well, we do like the IGRA. It's first of all, it is more expensive, and there are some limitations in terms of age related. With children, for example, probably not under 2 years of age. So those are probably two factors that I look at as a clinician myself. Pam, do you have any comments about that? Pam deals with this all the time.
In contact investigations, the standard is to do an IGRA on all contacts. The exclusion would be, for example, in the Department of Corrections, where we're testing hundreds of people at one time, and they are in a confined area. So we know that placing the skin test and reading the skin test is not going to be that difficult because, they're a captive audience. But we do, unless there's some reason that we are not able to get blood from an individual, we do try to do the blood test on all contacts.
You know, the thing about IGRA, I do predict in my career with tuberculosis, which probably will still be even longer if my health holds up, that we will continue to get more information on IGRA. I have not had the opportunity to read an article that just came out in pediatrics by Dr. Jeffrey Stark. Again, as I mentioned, from Baylor, who is a very widely respected expert on pediatric tuberculosis, and he has just written an article on IGRA and TB skin tests. So again, I believe that we will be continuing to use that test more, and I think at some point the TB skin test is going to go away. I mean, it's a very old test, but it's what we had, and it served us well in TB control. But I think in the future we'll continue to have better testing, and I think IGRA will become something that will be less expensive to use and more applicable in wider age groups.
Thank you.
Are there other questions that I can answer? Do we have any call-in or internet questions?
We don't have any email questions at this point.
Okay. Very good. Well, again, let me just say that the Alabama Department of Public Health considers it a great privilege to be able to participate in this program, not only for our state, but for our other states that may be listening in this morning. And we're happy to interact and have contact with other states regarding TB control. I mean, we regularly work with TB control in other states and find that relationship to be most beneficial to our patients. All of us want what's best for our patients, and we want them to have a good journey with us so that they can recover from tuberculosis and lead a healthy, active life. So, Pam, I'll turn it back over to you.
Well, thank you very much, Dr. Landers, for joining us today, and thank you, viewers, for those of you watching out there. And we want to strongly encourage you to join us next Thursday at 10 a.m. Central Time for the second half of this discussion. Thank you very much.
Thank you.